all of you. A warm welcome to our Zoom webinar organized by GMOA 3 Knowledge Academy. Kindly mute your microphone and turn off the cameras during the presentation and use the chat box to clear your doubts at the end of every session. Now it's my pleasure to introduce Dr. Mahesh J. Gamage, Consultant Eye Surgeon currently attached to Colombo Teaching Hospital, Ragama. And his lecture is going to be on common eye conditions presenting to OPD setup. Over to you, sir.
Good morning, everyone. First of all, I would like to thank GMOA and 3 Knowledge Academy for organizing this kind of series of lectures to improve the knowledge of our medical officers and thereby to improve the patient care services. Today, during my talk, I'll be talking about common eye conditions presenting to OPD setup. As primary care physicians, what these all other doctors should know and what they should do when these conditions, then they met up with these conditions. During my slides, you will see a red star like this. And that means that is something which is really important and two things to remember and kind of take home messages. So just pay attention for those slides, quite vigilant about this red star. I'll be first dealing with these common presentations: cataract, glaucoma, diabetic eye diseases, refractive errors, and ocular trauma. And what is cataract? Cataract is the loss of transparency in the human crystalline lens. This is a schematic representation of the optics of the eye. When somebody is looking at an object and a mirror image is formed inside the eye on the retina, and these light rays converge to the what is called nodal point, which is situated just behind the lens, just behind the posterior capsule of the lens. So as you can see, the light rays converge here at the nodal point of the eye in the human optics. There are several morphological types of cataract, and most common is the nuclear cataract, which is sclerosis and gradual loss of transparency within the central nuclear part of the cataract, or nuclear part of the lens. And there can be cortical cataract, that is clouding in the cortical areas of the lens, and maybe clouding or opacification in the posterior subcapsular area, and maybe posterior polar cataract, and maybe anterior polar cataract or pyramidal cataract, or there may be kinds like lamellar cataract. So as you can see, not all these cataracts are visually significant. As I showed in the last slide, the nodal point of the eye lies just behind the posterior capsule. So cataract like posterior polar cataract or posterior subcapsular cataract impairs light entering into the eye more than these cortical cataracts. On slit lamp examination, there are so many morphological types of cataract that we can see. These are the some of the cataracts as seen here. This is a total cataract, which is a mature cataract. The entire lens is cataractous, as you can see here. Or there can be nuclear cataract, just the central part of the nucleus of the lens is cataractous. Rest of the lens is quite clear. Or can be anterior polar cataract, where just the anterior pole is cataractous, as you can see here. So light can enter into the eye through the rest of the lens. Or it can be posterior polar cataract or posterior subcapsular cataract, where it's just behind the, just anterior to the posterior pole. And as you can see, remember the nodal point, these cataract can impair the vision to a greater extent. It can be lamellar cataract, where only a certain lamellae of the lens is cataractous, as you can see in most of the congenital cataracts. And there are so many other kinds of cataract: cortical cataract, nuclear cataract, and sutural, Christmas tree, sunflower. So There are so many various kinds of cataract, but not all these cataracts are visually significant. Again, this is a closer view of some of the cataracts. This is a posterior subcapsular cataract. This is a nuclear cataract, and there's a mature cataract here. The entire lens is very much cloudy. And this is a Christmas tree-like cataract. And this is a hypermature cataract where, as you can see, the dense nucleus is gravitated down, and whereas the liquefied cortical matter is dissolved and fill the rest of the capsule. And as I said, not all cataracts need surgery. If they are not visually significant, and if they do not affect patients' visual requirement, and if there is no other comorbidities, that can be left alone without any interventions. Some of the congenital cataracts, they are not visually significant and of course not progressive and therefore we can leave alone. So then comes the question, when do we need the cataract surgery? The answer is when an individual has visual impairment due to cataract resulting in visual disability. So there should be a visual impairment which is due to cataract, and that should result in visual disability. Visual disability is a visual impairment which affects individuals' activities of daily life, occupation, or etc. Here, as you can see, this depends on each and every individual. So every individual's visual requirement is different. So the visual disability is different. For example, if you see a driver who has 6/6 or 6/9 vision, but has early posterior subcapsular cataract, may have significant glare and halos, especially when nighttime driving. So in that case, he may need cataract surgery. In compared to a elderly woman who is just roaming within the house, may be happy with 6/18, 6/24 vision and may defer the cataract surgery. So clearly speaking, there are optical indications and therapeutic indications. The optical indications, the visual symptoms, gradual loss of vision, reduced color or contrast perception, and glare and halos. As I said, it is not only the quantity of vision, but quality of vision is also important with regard to the patient's visual requirements. There are some therapeutic indications where we do cataract surgery, such as if the cataract is causing secondary glaucoma, like in phacolytic glaucomas or phacomorphic glaucomas, or if a cataract causing poor fundal visualization, so that we cannot assess the fundus or manage the fundal pathologies like diabetic retinopathy. In that case, we may do cataract surgery in order to get a better fundal visualization. Surgery, of course, we do phacoemulsification and IOL implantation. This surgery is done under local anesthesia through a very small incision. It's about 2.2 millimeters or maybe sometimes 2.6 millimeters. And you need to encourage people with cataract to have these cataract surgeries done. There's nothing to fear about. In fact, this is the most successful surgery, most successful outcome of all the surgeries in the world, achieving about 98 to 99% of success. Of course, there are complications, there can be, but the success rate is around 98 to 99%. There are certain instances where we may not be able to do the phacoemulsification. Then we do what is called extracapsular cataract extraction. There we need to make a relatively large incision, about 13 millimeters, and take out the entire lens in bulk and implant an artificial lens. And of course, this needs suturing. And rarely we perform what is called lensectomy, so intracapsular cataract extraction, where we take out the lens and the capsule both together and do a secondary IOL implantation. So mostly what we do is phacoemulsification with a very high success rate. So just educate the public or the people with cataract. There's nothing to worry, and encourage them to have cataract surgeries to avoid what is called preventable blindness. And next we will talk about glaucoma. Glaucoma is a progressive neurodegenerative disease affecting the optic nerve with characteristic changes in the optic nerve head and corresponding visual field loss. So there are some important words here, which is a progressive neurodegenerative condition affecting the optic nerve head, and there should be corresponding visual field loss. And it is not synonymous with raised intraocular pressure. That is just a one feature of glaucoma. So don't go away that high intraocular pressure is glaucoma. Of course not. And so we call glaucoma silent killer of vision. This is a basic classification of glaucoma. It can be open angle, low angle closure, depending on the open or closure of the anterior chamber angle. And it can be primary or secondary. Angle closure can also be primary or secondary. So we call primary open angle glaucoma, or we can call secondary angle closure glaucoma. And there are so many causes for this open angle and angle closure glaucomas, but this is the basic classification of glaucoma. And there is a something called glaucoma triad. As I said, raised intraocular pressure is not synonymous with glaucoma. And here raised IOP is one feature where the intraocular pressure is more than 21 millimeters mercury. The normal range is about 10 to 21. And if it is more than 21, we consider it as high intraocular pressure. And that can be seen in glaucomas except for normal tension glaucomas. And the second feature is abnormal disc appearance or the glaucomatous disc damage. There are several features I will discuss with the pictures later, namely cup disc ratio asymmetry and large cup to disc ratio for disc size and integrity of the neuroretinal rim, notching and thinning, disc hemorrhages, vessels bayoneting, and peripapillary atrophy. These are all features of glaucomatous disc damage. And there should be corresponding visual field defects. There can be nasal steps, paracentral scotomas, aqueous scotomas, attitudinal scotomas, or residual temporal or central island of vision as seen in advanced glaucoma. As primary care physicians or the first contact care doctors, I think everyone should be quite competent in direct ophthalmoscopy. And when you assess the fundus with direct ophthalmoscopy, this is how you should assess the disc with regard to the glaucoma. Basically, you need to see the size of the disc, shape of the disc, color of the disc, and this assessment for the glaucoma. So this red circle shows off the entire area of the disc, and you can assess the vertical diameter of the lens, rough assessment. And this blue circle is the covers the cup, which consists of neuroglial tissue or the supportive tissue within the optic nerve head. And between this red and the blue circle is the neuroretinal rim, which consists of axons of the retinal ganglion cells, which is the true neuronal tissues of the optic nerve. So what is important is the amount of true neuronal tissues or the neuroretinal rim within this optic disc. So we assess the diameter of the disc ratio to the diameter of the cup. So basically the vertical is quite more important than the horizontal diameter. So we assess vertical cup to disc ratio. It can be generally about, we can say it is 0.3 to 0.4 like, but that all depend on the size of the disc. Smaller disc, cup disc ratio is quite more significant than a cup disc ratio of a larger disc. This is a picture to assess the cup disc ratio. As you can see here, this is the entire thing is the disc, and this central whitish or the yellowish part is the cup. The cup disc ratio here is about 0.5. Again, this is a clear picture. This entire thing is the disc, and this is central part is the cup, and the pinkish area is the neuroretinal rim. and you can assess the cup-disk ratio. The most important thing is the integrity of the neuroretinal rim, which consists of, as I said, the axons of the retinal ganglion cells, which consisting of the optic nerve, which is thickest inferiorly, and then superior, and then nasal, and then temporal. So if you assess the integrity of this neuroretinal rim, which obeys the Eisen rule, inferior thickest, then superior, then nasal, then temporal. So always assess whether this disc complies with the Eisen rule. These are some changes in the optic disc with glaucoma. There's quite early cupping in this disc. There's about 0.6 cup disc ratio. Again here there's about 0.6 cup disc ratio. And again another disc with early damage, about 0.6 cup disc ratio with the flame-shaped hemorrhages at the disc. And here there are some nerve fiber layer defects as well. This is quite a moderate glaucomatous disc here. As you can see, there is thinning in the neuroretinal rim inferior and superior. Here it is more visible. The inferior neuroretinal rim is has quite thinned out here. The cup disc ratio about 0.75, 0.8 like. As you can see, this should be the thickest inferior, but it is thinnest inferior. So there is a glaucomatous disc damage here. This is advanced glaucomatous disc damage. You can see overall cup disc ratio is about 0.9 with severe thinning inferior and superior associated with peripapillary atrophy, which is atrophy area around the optic disc. Here again, there's a severe thinning, superior and inferior with a 0.9 cupping and peripapillary atrophy. Again, this is another picture of a glaucomatous disc damage with a 0.9 cupping with severe inferior and superior thinning with peripapillary atrophy. So when you are doing direct ophthalmoscopy, you can assess the integrity of the neuroretinal rim, the superior and inferior thinnings, and the amount of the cup disc ratio and the asymmetry of the cup disc ratio between the two eyes. If the cup disc ratio is asymmetry is more than 2, then that is quite significant. For example, if one eye has cup disc ratio of 0.3 and other eye has cup disc ratio of 0.7, then of course there is a asymmetry in the cup disc ratio, which is quite significant. And these are some examples of visual field defects seen in glaucoma. Here, this central, this is the blind spot, and you can see a nasal step here. This is kind of an early glaucomatous damage, and this is the blind spot, and this is in the left eye. There's a paracentral scotoma here, and there's a temporal wedge-shaped scotoma here. There's altitudinal field defect, which means the entire superior half of the visual field is lost, and there's arcuate defect, and there's advanced glaucoma with relatively spare in the central island of small part of the vision. And the most important thing in the visual fields is these visual field defects obey the horizontal midline. They don't cross the horizontal midline, as compared to the neurological type of visual fields where they obey the vertical midline. The most important thing is these glaucoma patients are mostly asymptomatic. That's why we call them silent killer of vision. Since they become advanced stage, they don't present, and they present with advanced stages of glaucoma with tunnel vision. Therefore, and by that time, there's very little that we can do. Only thing is acute glaucomas can present early, then they can present with painful red eyes, clouding of vision associated with ipsilateral headache, nausea, vomiting. And so these kind of patients mostly present into OPD setup with very high sudden onset, high eye pain plus headaches, and they maybe end up in medical wards doing all sort of investigations, including CTs and MRIs. And but ultimately they can be diagnosed as acute glaucomas. For example, acute angle closure attacks, phacolytic glaucomas, and phacomorphic glaucomas. So things to remember here is, if patient coming with sudden onset of severe headache, painful red eye, just have a look at the eye. And if the eye is looking congested, red, and cloudy cornea, just think of acute glaucoma as well and refer patient to a eye unit rather than planning for all sort of investigations. These are some examples of acute glaucoma. This patient has congested red eye, hazy cornea, mid-dilated and non-reactive pupil, and he will have very poor vision. And again, there's another patient with a diffusely congested eye, hazy cornea. And in this patient, there's a diffusely congested eye, hazy cornea, and you can see there's a mature cataract. So these two patients are having angle closure glaucoma attacks, and this patient is having a phacolytic glaucoma attack. So if a patient coming with like this, just have a look at the eye, and if it looks so congested with these hazy corneas, and get an ophthalmological opinion before proceeding with other investigations. So the take-home message is glaucoma screening, since it is not it has a long silent phase. We have to do the glaucoma screening in order to detect them early. All above 40 years should be screened every 5 to 10 years, and if they have positive family history, they should be screened every 5 years or so. Or if they have secondary causes, mostly they are followed up in ophthalmological clinics, and we need to screen them according to their the reasons, such as long-term steroid use, ocular trauma, uveitis. So everybody above 40 years should have an glaucoma screening every 5 to 10 years. And if they have a positive family history, and then we need to screen quite more frequently. So the take-home message, glaucoma is a silent killer of vision. They present at that advanced stage where we can do very little. Therefore, be a detective to spot the killer. So practice direct ophthalmoscopy in your routine clinic practice, and do optic disc evaluation, and which can be done with a direct ophthalmoscope in a dilated fundal examination. And if you have any doubt, you can refer the patient to the nearest eye unit for further evaluation. And next we will move on to another very important topic, diabetic eye disease. Diabetic eye diseases are a group of conditions that can affect people with diabetes mellitus, and all forms of diabetic eye diseases have the potential to cause severe visual loss and blindness. So this includes diabetic retinopathy, diabetic macular edema, cataract, and glaucoma. We have dealt with these two earlier, and they are more prone for infections, ocular surface infections, and intraocular infections as well. Diabetic retinopathy. If somebody asks what is diabetic retinopathy, the answer is it is a microangiopathic complication of diabetes mellitus affecting the retinal circulation. There are some pathophysiological changes within the retinal microcirculation. They include loss of pericytes within the retinal arterial system, and thickening of the basement membrane, and increased permeability, which results in both microvascular leakage and occlusion. This is the pathophysiology of diabetic retinopathy, giving rise to all these complications. And this is a simple classification of diabetic retinopathy. As medical officers, I think everybody should be familiar with this classification. This is the classification that we are used for the diagnosis and management purposes, as well as research and study purposes. Either they don't have any diabetic retinopathy, or they maybe have non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. So NPDR is again divided into mild, moderate, and severe. PDR is divided into early, high risk, and advanced PDR. Everybody should be familiar with this International Diabetic Retinopathy Disease Severity Scale, which, as I said, is the scale that we are using for diagnosis and management purposes, as well as research purposes. There's no abnormality, of course, there is no diabetic retinopathy. And NPDR, or the non-proliferative diabetic retinopathy, divided into three, as I said earlier: mild, moderate, and severe. Mild is there are only microaneurysms. Severe is there is 4-2-1 rule. 4 means more than 20 intraretinal hemorrhages in each of the 4 quadrants. In each of the quadrant of the eye, there are more than 20 intraretinal hemorrhages, that is 4. 2 is there's definitive venous bleeding, venous changes in 2 or more quadrants, and 1 is presence of prominent intraretinal microvascular abnormalities in 1 or more quadrants. So this is 4-to-1 rule. So if they have 4-to-1 rule, either one of the 3, then they fall into severe NPDR. In between the mild and moderate is mild and severe is the moderate NPDR. And then the PDR, or the proliferative diabetic retinopathy, there's one of the followings: presence of retinal neovascularization, retinal within the disc or elsewhere in the retina, or angle, new vessels at the angle, or new vessels in the iris. So presence of neovascularization will fall them into PDR category, and presence of vitreous and preretinal hemorrhages. So we will go through some pictures for you to become familiar with these signs. In this picture, you can see there are a lot of dot-like hemorrhages. These are the presence of microaneurysms, and there are some blot-like hemorrhages. These are the presence of intraretinal bleeding hemorrhages. As you can see, if you draw a line vertically and horizontally across the macula that divides the retina into 4 quadrants, and if you roughly assess in each of these 4 quadrants, there are more than 20 microaneurysms or hemorrhages. If you just draw a line vertically, horizontally, in each of the quadrant, there are more than 20 microaneurysms or hemorrhages. So this retina falls into severe NPDR category. There is the rule number 4. In this fundus, you can see there's a lot of exudates here, quite close to the macula, and some intraretinal hemorrhages and microaneurysms. And here this explains the venous changes, the dilatation and tortuosity of the veins, and beading. You can see the beaded appearance in these veins here. So presence of venous beading in 1 or more quadrant, in 2 or more quadrant, falls the patient into severe NPDR category. And this is a fundal fluorescein angiogram photo to show the intraretinal microvascular abnormality, or the ERMA. Presence of ERMA in 1 quadrant is falling the patient into a severe NPDR category. And this is again a patient with, there are a lot of intraretinal hemorrhages, a lot of exudates all around, and a lot of microaneurysms and hard exudates, looping capillaries, and some venous changes, venous beading here. So this patient has severe NPDR. And this is the presence of proliferative diabetic retinopathy, where you can see the presence of new vessels. These are abnormal, friable, fan-like new vessels, which can be on the disc or within 1 disc diameter of the disc area, and that categorized as neovascularization on the disc, or NVD, or there can be this kind of neovascularization elsewhere in the retina, as you can see here. So we call them NVE, neovascularization elsewhere, and this is NVD, neovascularization on the disc. And again, there's another patient with NVE. There's neovascularization elsewhere in the fundus, and there's severe NVD here. And this patient has preretinal hemorrhages here on the surface of the retina, as well as some vitreous hemorrhage. So this patient fall into PDR category. And this is a picture of the advanced diabetic retinopathy, where there is fibrovascular tissue formation and tractions on the retina with tractional detachment. And this is kind of a severe or the advanced PDR. So important thing is to remember is screen for diabetic retinopathy. As you know, when we come to these stages, there's much we can do. So it's really important for diabetic retinopathy screening. The international guideline is for type 1 diabetes, we should screen them within 5 years of diagnosis, and then annually thereafter, or as appropriately if they have diabetic retinopathy. For type 2 diabetes, we should screen them on diagnosis and then annually thereafter. The reason is type 2 diabetes have a long subclinical phase which has been there undetected. So quite a significant number of patients will have diabetic retinopathy on diagnosis. Whereas type 1 diabetes have a very short subclinical phase and very little patients will have retinopathy on diagnosis. So type 1 within 5 years, type 2 on diagnosis, and then annually thereafter, or as appropriately if they have diabetic retinopathy. And gestational diabetes mellitus or diabetes in pregnancy, they should be screened on the first antenatal clinic visit, and then if they have no diabetic retinopathy, should be screened again around 28 weeks of POA, or if they have the diabetic retinopathy, then screen as accordingly. And this is really important. The system, the management of diabetic retinopathy, it has two folds: the systemic management and ocular management specifically. So systemic management, as shown in these landmark clinical trials, UKPDS, DCCTO occurred trials, there's a very significant role in systemic management. The optimum control of systemic risk factors like strict control of blood sugar, tight control of blood pressures, lipids, and correction of anemia, and engage in regular physical exercise and stop smoking. These do really important, because whatever we do as eye surgeons will not be quite useful or efficient or effective if the patient's systemic management is not optimized. So as primary care physicians, it is really important for you to get involved in the systemic management of diabetic retinopathy. So specific ocular management, as I said, no diabetic retinopathy, mild NPDR or moderate NPDR is just the systemic management. When it comes to severe NPDR or maybe PDR, we consider doing retinal, panretinal photocoagulation, or sometimes if it is quite advanced, surgery, the vitrectomy. So that is specific ocular management. And then we'll talk about something about the diabetic macular edema, which is as a consequence of diabetic retinopathy, there can be a swelling in the macula, which is called diabetic macular edema. As you can see here, there's the macula. There's quite a lot of retinal thickening and swelling within the region of the macula. And here there are a lot of hard exudates, retinal thickening and swelling. This, of course, you can see clearly when we are examining with the slit lamp. When we have this 3D view, we can see there's a lot of macular edema or the swelling. This is a cross-section. This is what is called optical coherence tomography, or the OCT, which gives a cross-sectional study of the macula. As you can see, there's a lot of swelling within the layers of the retina and just under the retina also. So this is a patient with diabetic macular edema. The treatment options. This is, of course, diabetic macular edema specific ocular management. We do laser treatment for focal macular edema, or if there is diffuse macular edema, we do intravitreal injections, including anti-VEGF or steroid injections, or if they have advanced diseases with tractions, we might think of doing vitrectomy and delamination with the peeling of the lamina. So the things to remember here is, in diabetic retinopathy, important thing is to how to screen properly. We still see quite a lot of patients coming quite advanced retinopathy. They have not been assessed for diabetic retinopathy after diagnosis quite for a long time, sometimes 5-6 years, even after 10 years, until they come with complications, their eye have never been screened. So it's quite important for screening for diabetic retinopathy and get involved in systemic management of diabetic retinopathy. And then we will talk about some other common presentations to OPD and GP setup. One important thing is loss of vision. If somebody come into your practice with loss of vision, uh, take a brief history, whether it's acute loss of vision or whether it is a gradual loss of vision. If it is acute, is it whether within seconds or minutes or within days or weeks? Sometimes patient might come complaining just losing the vision within seconds, within minutes. It's a very sudden event. So that is quite very important when compared to gradual deterioration of vision over a period of months or years. And whether it is painful or painless, and especially central, peripheral, or transient versus prolonged, whether it is a transient loss of vision, which just losing vision and comes and goes like, or whether it stays there on long-term basis. And then at OPD setup, you can assess these patients with a visual acuity with a standard Snellen's chart, unaided, and with their spectacles and with pinhole correction. And you can just do a torch examination to see whether there's any abnormality on the ocular surface. If you are familiar with, do a pupillary reflex and red reflex examination with the torch, and if possible, do a fundal examination with the direct ophthalmoscope. This everything can be done at a OPD setup to diagnose whether this is a quite acute or very emergency situation, or whether where you have to refer the patient to eye unit quite urgently, or whether you can wait. There are a whole lot of causes for loss of vision. One thing is refractive error. There's a poor vision, maybe an incidental finding, and the vision improve is the pinhole, and there's no gross abnormality of the eye when we do a refraction and give spectacles. There are basically three kinds of refractive errors: myopic errors, hypermetropic errors, and astigmatism. And there are some other conditions with corneal ectatic disorders and like keratoconus, which is we do in eye care, is quite important at OPD setup. And this is really other thing is painless gradual loss of vision with a normal red reflex. There's slow loss of vision, and which is painless. One example is chronic open angle glaucoma. As you can see here, there's advanced glaucomatous disc damage where the patient has significant loss of peripheral vision. And another gradual painless loss of vision with normal red reflex, as I told you earlier, diabetic retinopathy and diabetic macular edema, that also one cause for gradual loss of vision. Another cause for gradual loss of vision is macular degeneration, where the center of the macula undergoes degenerative changes. And another cause is optic atrophy, gradual pale loss of vision. And the other things like ocular surface diseases, there's a whole lot of ocular surface diseases. So this can be diagnosed just by a torch examination onto the cornea if you see a clear cornea, or whether there's anything on the cornea. And the other reason is cataract, as I said earlier. And painless but sudden loss of vision, transient episodes. It can be amaurosis fugax, which is quite important. It is kind of a transient ischemic attack affecting the retinal circulation. Or there's a condition called migraine sign migraine, where patients get visual symptoms without having headache. So that can be a cause for transient loss of vision, the episodic pattern. And the other causes are vitreous hemorrhages, retinal detachment. And this is really important. Painless sudden loss of vision, central retinal artery occlusion. This is quite important for you all to be familiar, because this is an ophthalmic emergency. If we intervene on time, like basically within 4 to 5 hours, then there's a chance of visual recovery. Patients will complaining of sudden, profound visual loss, which is an acute event. It is not a slow thing, it's just acute. All of a sudden they lose vision, and that is very profound loss of vision. And if you can assess the red reflex, there is a significant relative afferent pupillary defect, which is very obvious. If you if you know how to do the red reflex, know how to do the pupillary reflex, there is a significant relative afferent pupillary defect. And if you just peep into the fundus, you can see a pale fundus with the central cherry red spot. If you can diagnose this central retinal artery or suspect central retinal artery, refer the patient to an eye unit as urgent as possible. This is an ophthalmic emergency. If we intervene, there's a chance of recovering vision to a certain extent. But if the time passes like more than 5-6 hours, then chances are very limited. And again, there's another cause for sun loss of vision, central retinal artery occlusion, and other causes like anterior ischemic optic neuropathy, arteritic, non-arteritic, posterior ischemic. All these are causes for sudden and profound loss of vision. Optic neuritis and cortical visual impairment. And this is a cause for painful sun loss of vision. As I said earlier, acute angle closure glaucoma, patient coming with severe pain, congested eye, hazy cornea. So just do a torch examination, and if you suspect, refer the patient to our unit. And then we will talk with some other red eye causes. Just take a preceding history as to the patient, what has happened, whether it is painful or painless red eye, whether the visual acuity is normal or reduced. How about other symptoms like tearing, discharge, fever? There are again a whole lot of causes for the red eye, starting from the conjunctiva, as in conjunctivitis, dry eyes, pterygium, subconjunctival hemorrhages, trauma, and then cornea, corneal aberrations, corneal foreign bodies, corneal lacerations, ulcers, keratitis, and then sclera, episcleritis, scleritis, and the inflammation within the eye, the iritis and iridocyclitis, anterior chamber hyphemas, angle closure attacks, and orbital cellulitis, acute acrocystitis. There are a whole lot of causes for red eye. So just basically do a torch examination. If you see an abnormality, refer the patients to the eye unit. Pure and simple conjunctivitis, patient will have redness, gritty feeling, tearing and discharge. The important thing is vision is normal here and cornea is clear. Just flash the torchlight into the cornea and you will see a clear cornea, crystal clear cornea, and vision is normal. So in that case, you may treat these patients with antibiotics and lubricants, and ask the patient for the general hygiene and prevent the spread of the conjunctivitis. And if you see something on the cornea, it may be part of keratoconjunctivitis, which means the conjunctivitis plus that involvement of the cornea as well. In that case, vision may be blurry. So in these cases, just refer the patient to an eye unit. Common mistake that you should never do is never ever use steroids for undiagnosed ocular conditions. This is a common practice where we see patients are given pro-beta N and betazole N. These are the common two kind of combination eye drops, the steroid plus antibiotic combinations given for these undiagnosed ocular conditions. We see quite a lot of patients with corneal ulcers are treated with these, and then mind you, that can lead to devastating complications. The dry eyes, patient will complain of ocular discomfort, stinging and gritty feeling, and photosensitivity, redness, and of course the treatment is lubricants. Pterygium, this is a condition with there's a fibrovascular growth onto the cornea, which is classically on the nasal aspect of the eye. Rarely it can come from the temporal aspect, which we call pseudopterygium, which happens due to the ultraviolet light damage to the limbal stem cells, and then subsequently these fibrovascular tissues grow onto the cornea. The management is early cases. We may manage conservatively, ask the patients to avoid direct sunlight exposure, to use an umbrella or wide-brimmed hat, and use a ultraviolet filtering and fully covered sunglasses. Not just sunglasses, it should be ultraviolet filtering and fully covering sunglasses. If it extends, as in this case, onto the cornea, when we call it grade 3, then we do surgery. Subconjunctival hemorrhage is again quite a common presentation. There's a diffuse subconjunctival hemorrhagic patch. Can be due to trauma, eye rubbing, valsalva maneuvers, or hypertension. If there is no other preceding history, patient can be managed conservatively. There's no treatment necessary, but just check the blood pressure. It can be due to sudden accelerated hypertension or other valsalva maneuvers. If it is due to trauma, patient need to be evaluated for uh, other damages of the trauma, so refer the patients to the eye unit. Corneal foreign bodies. If a patient coming with red eyes and gritty feeling, just if you flash the light onto the cornea, if you see something on the cornea, it may be a foreign body. So this need to be removed at the slit lamp and covered with antibiotics. And again, a patient coming with red eye, you flash the light onto the cornea and you see something on the cornea, it may be an early corneal ulcer. And never ever use steroids in this kind of corneal ulcers. It can give rise to devastating complications. Patient might end up in losing the eye, and we have seen quite a lot of patients who has been treated with steroids and ultimately losing the entire eye. So how much small the corneal ulcer is, refer to the eye unit. Episcleritis, scleritis, these are maybe isolated or as part of systemic conditions and maybe systemic associations, so we manage them accordingly. And this is intraocular inflammation, iritis or iridocyclitis. Patient may come in with specifically circumcorneal redness and blurred vision and photophobia. This is in contrast to the conjunctivitis, where you get redness more on the fornices, and there's no blurred vision, there's no photophobia. But here in iritis or the iridocyclitis, basically the intraocular inflammation, patient will have blurred vision and photophobia. And again, orbital cellulitis, where there is periorbital swelling, signs of inflammation, pain, red eye, restricted eye movements, blurred vision, RAPD, and patient may be having fever and systemically illness. So management involved with intravenous antibiotics and specific ophthalmological management. Again, dacryocystitis, there is a painful swelling just inferior to the medial angle of the eye. And this is kind of a acute dacryocystitis where the lacrimous sac is blocked and then subsequently getting secondarily infected, and treatment with systemic antibiotics plus subsequent surgery. Another important symptom patient coming to the OPD is seeing double. Either it can be a vertical diplopia or a horizontal diplopia. There are a whole lot of causes for seeing double, including neurological, neuromuscular, mechanical causes, including trauma, and patient need to be have proper ophthalmic evaluation. There are a whole lot of causes here. And this is another important aspect, orbital and ocular trauma, because as first contact care physicians, you will be the doctor who the patients are presenting to. Early management of this ocular trauma is really important, because subsequent specific ocular management or the ophthalmic management, the success will depend on the early management. Types of trauma can be physical or chemical trauma. Physical trauma can be blunt trauma or penetrating injuries or burns, chemicals or alkaline acids or other chemicals. Physical trauma, as I said, can be blunt trauma with blunt objects like tennis balls, rubber balls, assault with bare hands or some other clubs like shuttlecocks, toy bullets. A whole lot of blunt objects can go blunt trauma into the orbit or the eye. And penetrating injuries with sharp objects like knives, scissors, pencils, eagles, sticks, needles, shrapnels, metal objects likewise. So blunt trauma, it can give rise to a whole lot of complications from front to back into up to the optic nerve. The orbital injuries, they can give rise to periorbital hematomas, little lacerations, fractures, especially involving the inferior or the medial wall of the orbit. And sometimes it can be associated with Lee-4 type 2 and type 3 fractures. And as this seen in this CT, there's a fracture of the inferior orbital wall, and there's a classical teardrop sign here. And if you compared it with the other side, there's a fracture in the inferior orbital wall. Lid lacerations. Lid lacerations can be involved in the lid margin or may not involve the lid margin. If it does not involve in the lid margin and if it is not very deep, and it can be managed at OPD setup, you can just examine the eye to see whether there is any associated ocular injuries. If there is no associated ocular injuries, if it is isolated lid laceration not involving margin, then you can suture them at OPD setup. But if it is a deep laceration which involves the muscles and the tendons, and if it involves the lid margins or the canthus, or if it involves the lacrimal system, that has to be managed in an eye unit, because proper alignment and repair of the lacrimal system, repair of the cantha is needed. So do not attempt to suture these lacerations where they involve the margins or the cantha or the lacrimal system. This is a picture of a lid laceration involving the margin. And other thing I want to tell is always assess for other associated ocular injuries. This is a lid margin involving lid laceration. This need to be managed in an eye unit. The proper alignment of the lid margin is really important for the proper function of the lid. And there's quite a complex lid laceration involving both lid margins here. Luckily, the globe seems to be intact. And other blunt trauma, they can give rise to subconjunctival hemorrhages, corneal contusions, hyphemas, traumatic uveitis, angle recessions, iris sphincter tears, iridodonesis, lens subluxations, dislocations, vitreous hemorrhage, commercial retinal tears. So there's a whole lot of damages that can caused by blunt trauma from top to bottom. So they need to be assessed properly. And yeah, this is a subconjunctival hemorrhage, as I explained earlier. This is a hyphema where bleeding into the anterior chamber in the eye. There's blood in the anterior chamber. And there's a dislocation of the lens here. As you can see, there's a retinal tear here and retinal detachment as a result of blunt injury. And then we'll move on to the penetrating injuries. And these caused by sharp objects which traverse through and through the eye, like splinters, knives, scissors, pencils, pens, likewise. And that can be also with very high velocity projectiles, such as in blast injuries, small shrapnels, and stones, and yeah, thrown away when cutting grasses like that. The type of penetrating injuries, again, there can be conjunctival lacerations, partial thickness corneal laceration, full thickness corneal laceration, scleral lacerations, globe rupture with prolapse of intraocular contents and loss of intraocular contents, and maybe lacerations with intraocular foreign bodies. This is a picture with a corneal laceration with prolapse of the iris through the corneal laceration here. Again, another picture of the corneal laceration here with a prolapse of iris through the laceration. As you can see, there's a peaking of the pupil here. Again, there's a peaking of the pupil. If you just flash a torch onto the cornea, you will see there's abnormality, and the abnormality on the ocular surface on the cornea, as well as there is the peaking of the iris. So suspect penetrating injuries. Again, there's a clear corneal laceration with corneoscleral laceration, which is extending onto the sclera, bleeding. And here again, there's a corneal laceration here. Again, there's a cut cornea, and that's cut through and through the cornea and the sclera. Again, this is a sutured corneal laceration. So things to remember is patients suspected of having penetrating eye injury should always be managed in an eye unit. As primary care physician, what you should do is do not wash the eye or put any medication. Just put a drop of preservative-free antibiotics if you have, like moxifloxacin preservative-free, and put a sterile eye pad and prepare the patient for surgery under general anesthesia. So if into your practice, if a patient coming with penetrating eye injury, you just flash the light, you see there is a damage in the eye. So do not go for further evaluation into detail of the examination. If you suspect penetrating eye injury, just put a preservative-free antibiotic, and if you have an sterile iPad, and keep the patient fasting, and ask the patient to go to the nearest eye unit or refer the patient nearest eye unit. And if the patient has other medical records, ask the patient to take those records as well as a preparation for general anesthesia. Do not press the globe for any reason, as that may cause prolapse of the intraocular contents and further, and you may be damaging the eye, which has already damaged. And then chemical injuries and burns. So the common chemical agents are the acids, alkalines, and other chemicals. Acids such as acetic acid, sulfuric acid, alkalines such as lime, and thermal burns like fire, incense sticks, hot oil, fireworks. Chemical injuries, alkaline burns are more worse than the acid burns because they can stay on the ocular surface quite for a long time, and they can penetrate the cornea much more worse than the acids. So management, again, this is really important. This is because these patients are coming to your practice with chemical injuries to eye. So whatever you do in your practice has a really important in the ultimate visual outcome. So do the ABC in case of serious systemic involvement, airway, breathing, circulation, and do a thorough irrigation of the eye with copious amount of clean fluid, maybe water, maybe saline. So what is really important is do a very thorough irrigation of the eye, at least half an hour. Ideally speaking, we have to do the cleaning until the pH becomes neutral or the litmus papers become neutral. But practically we don't have that facility. So irrigate the eye as much as possible, at least for half an hour with free flowing fluid like water or saline. And that has a real importance in the ultimate visual outcome. This is a patient with a severe alkaline burn. Although the eye looks very white, this is very alarming because this entire conjunctiva sclera, entire thing is damaged, necrotic, and the blood supply to the entire anterior segment of the eye is damaged, compromised. So ultimately, patient will end up in losing the eye. Thermal injuries, common injuries like welding arcs and eye needle in the burn patients. And so what we need to do is, again, put copious amount of lubricants, topical antibiotics, steroids. This is specific management at eye unit. And again, eye injuries is quite common at home, schools, and road and workplace. It is very common everywhere. And take a good history and have a high degree of suspicion, and along with careful examination, do a, like at your setup, you can examine the eye with a torch. And the other thing is never give steroids to a patient with a history of eye trauma. And yeah, when in doubt, always refer. What is really important is prevention of eye injuries. Always advise the patients or the public, or whenever you come across with these risky procedures, ask them to wear a protective eyewear whenever they do these risky procedures. This is really important. So you can become involved in the patient education in the prevention of ocular trauma. Just regular glasses will not be effective enough. They need to be wear proper protective eyewear. And there are the miscellaneous conditions, small things that you may be encountering in your daily practice, like chalazions, which is a swelling in the middle of the lid, which is a swelling due to the meibomian gland obstruction and granulomatous inflammatory reaction. What you can do is ask the patient to do a warm compressions about 4 to 6 times a day and apply antibiotic ointment along the lid margin. No point in applying on the skin. They have to apply along the lid margin after warm compressions for about 2 weeks. And if it is not settling, we might have to do incision and curettage under local anesthesia. And this is a stye commonly called, which is technically a hordeolum, which is at the lid margin. This is due to the blockage and infection of the sweat glands, and most resolve spontaneously, but you can help by doing warm compressions and giving antibiotic ointments applied along lid margins. This is a xanthelasma, which is kind of a deposition of lipids and cholesterol on the skin subcutaneous tissues. Ask the patient to do a lipid profile to see whether they have familial hypercholesterolemia. And this is a cyst of mole. This is a small, small cyst with clear fluid adjacent to the lid margin. They originate from the gland of mole and it's a benign condition. If the patient is really worried, we can excise it. And this is a cyst of size, which originate from the glands of size, again a benign condition. In contrast to the cyst of mole, this it has a solid appearance rather than a cystic appearance. Thank you. And yeah, I'm willing for any questions if you have.
Thank you very much, sir, for that informative presentation. So it's time to enlighten your queries. Yeah. Please write your questions clearly in the chat box. So I think we have already got 2 questions in the chat box.
Right, okay.
The first is, what is the medical management of glaucoma? I think you have elaborated in the lecture.
The glaucoma, I have not elaborated in the lecture here. The medical management of glaucoma is, the first choice is anti-glaucoma medications. We'll get into the glaucoma here. The first choice is the anti-glaucoma medications. There are a whole array of medications, prostaglandins and beta blockers likewise. So we do maximum tolerable medical treatment with following up with these visual fields and OCTs. And if the patient is deteriorating with the maximum tolerable medical treatment, then we go into the surgical treatment. Again, there are a whole lot of surgeries available, including the trabeculectomy and so trabeculectomy with mitomycin C. And there are special cases of glaucoma where we do trabecular shunt procedures, and there's laser treatment options like argon laser, ALTs, argon laser treatment, or selective laser trabeculoplasty. So a lot of surgical treatment is there depending on the individual case. So the first line treatment is medical treatment with anti-glaucoma medications. And the important thing to remember is this treatment is for lifelong. It's not just for a few months, not for a few years. Since this is a chronic progressive condition, the patient need to be on medications lifelong. It's really important for the compliance, because if we prescribe medications, usually they tend to stop. Okay, we have given for 3 months and we have completed 3 months, and then they stop and then they never turn up again to the glaucoma clinic, and then subsequently come with advanced stages. So it's really important to advise the patients that this is a lifelong medication and they need to be in regular follow-up in the glaucoma clinic to assess the progression. Sometimes when we use a medication, they can go secondary resistance. So we need to change the medications time to time. So it's really important for them to follow up in a medical glaucoma clinic, and medications to be used lifelong. And yeah, I hope that answers the questions.
So next query, I think it has several questions.
Yeah.
How to screen patients on long-term steroids? What are the things to look for? What is the minimal period to be on steroid treatment to screen?
Yeah, the long-term steroid use, whether it is a topical steroids used on the ocular surface or whether it's a systemic steroids, the complications of two most important complications are raised intraocular pressure and subsequent glaucoma, and the other thing is development of the cataract. There's no long-term steroid usage, but there's no time limit. Like, so if the patient is on this much of steroids for this long, they will get cataract. There's no such thing. Basically, if a patient is on long-term steroids, basically, if they're on systemic steroids and if the dose is high, then the risk is high. If the dose is very low, then the risk is low. And even topical steroids, depending on the potency of the steroids. For example, if somebody is on dexamethasone topically, about 33% of the patients will become steroid responders. And weaker steroids like fluoromethalone, then and that has quite a lesser, or loteprednol, there's a lesser risk of developing glaucoma or the cataract. So the thing is, it depends on the potency and the dosage and the duration of the steroid usage. And so basically patients on long-term steroids, for example, with systemic inflammatory conditions, they need to be screened for glaucoma and cataract from time to time. There's no specific time period as such. And if the patient is symptomatic, of course, blurring vision, they should be referred. Otherwise, like once in every few months, like 4 to 6 months, maybe.
Okay, sir. So the next question is, what are the types of lubricants we can use?
There are a lot of lubricants again. That depends on the situation. Ocular lubricants, you can use, there are preservative free lubricants and preserved lubricants. And for example, what we use in commonly Refresh Tears, Refresh Liquigel, Optive, and Systane Ultra likewise. That again depends on how the patient's clinical condition is, how severe the condition is. Like if the patient has quite a simple dry eyes, then something like Refresh Tears or Optive can be used, which is available commercially. There's no generic name as such. These are all combinations of medications. So quite commonly what we use is Refresh Tears, Refresh Liquigel, Optive, Systane Ultra, Systane, and Tears Naturale. There's quite a lot of things. And it's again individual and subjective treatment. Some patients do respond to one kind of lubricant drops and they don't tolerate the other one. So basically it will be, sometimes it may be on trial and error basis. And some are comfortable with some lubricants and not with the others.
The next question is, what's the management of scleral lacerations?
Scleral laceration, of course, surgery, the repair under general anesthesia. Patient is taken to the eye theater and should be repaired as early as possible. Whenever the fasting is completed, repair under general anesthesia in an eye unit.
Yeah. Next question, can migraine cause glaucoma?
Migraine, there is a clear association of migraine with normal tension glaucoma. Normal tension glaucoma is a condition where the intraocular pressure is within the normal range, but still patient has glaucomatous disc damage and corresponding visual field defects. And there is a clear association that with migraine, because that is again, migraine is again a vascular phenomenon. So this affects the optic nerve blood supply, and that can give rise to glaucoma, even though the pressures are not high.
Next question, how do we manage cyst of size?
How do we manage?
Cyst of size.
Yeah, cyst of size, again, cyst of size and cyst of mole, both are benign conditions. But if the patient is worried, if the patient is concerned about the cosmesis, we can remove them under local anesthesia. We do give local and excise and send for histology. And excision, of course, we have to do it completely, otherwise it can recur.
Another question on glaucoma. Can glaucoma get as familiar? Some patients complain family history of blindness.
Yes, there is a clear association, clear family history for glaucoma. That again, I explained here. Screening for glaucoma, positive family history, they need to be screened every 5 years, like, or every quite frequently. There's a genetic association because the glaucoma is a multifactorial condition. Intraocular pressure is just one thing. The other things are the positive family history, the genetics, and the blood supply to the optic nerve head, the thickness of the what we call the lamina cribrosa, the part of the sclera that the optic nerve passes through, and so which is a multifactorial condition, and of course the genetics plays a major role here. Yeah, patients with family history need to be screened quite frequently. They can have positive family history of blindness due to glaucoma as well.
Again on glaucoma, can myopia cause glaucoma?
Yes, that is again a clear association. Myopia, they can have quite more frequent on primary open angle glaucomas. There is association.
Next question, could you please tell about uveitis?
Uveitis is inflammation within the uvea. And let me get you this slide here. Yeah, uveitis is inflammation of the uvea. Uveal tissues is, there are three kinds of uveal tissues. One thing is iris, the other thing is the ciliary body, the other thing is the choroid. Uveitis is inflammation of one of these conditions, either iris. If it is iris, we call it iritis. If it is involved in the iris and the ciliary body, we call it iridocyclitis. And if it is in the choroid, we call it simple uveitis. So it can be again anterior uveitis and posterior uveitis, or panuveitis. If it is iritis and iridocyclitis only, then that is anterior uveitis. If it is the choroiditis, then become posterior uveitis. If it is involving everything, then that is panuveitis. And it may be as part of the ocular condition, or maybe as part of a systemic inflammatory conditions. And it can be isolated, or as I said, the systemic inflammatory conditions, or maybe ocular inflammatory infective causes. Yeah, as I said here, they present with specifically circumcorneal injections and pain, blurred vision, photophobia, and floaters. Yeah, so that is basically a simple explanation of uveitis.
Then the next question is, what are the common antibiotic ointments used?
Yeah, common antibiotic ointment, we can use chloramphenicol or fucithalmic ointment on the ocular surface. And if the infection is quite severe, we can use tobramycin ointment. And for a certain conditions, we use tetracycline ointments. Those are the basically common ointments we use apart from the drops. Common ointments we use chloramphenicol, or fucithalmic, and the tobramycin, tetracyclines, likewise.
So next question, if patient complains of curtains coming down like visual loss, what is the cause?
That again, there's a whole lot of causes. Curtain coming down means the visual field is losing from above to bottom. So there can be a retinal cause within the retina, like retinal detachment, or within the optic nerve, like in optic neuritis, or it can be something compressing the optic nerve, compressive lesions, or it can be sometimes in the visual pathway lesions affecting the inferior part of the visual pathway. Then yeah, it can be from the retina into the visual cortex, or the visual pathway up to the cortex. Yeah, conditions like retinal detachment, optic neuritis, compressive lesions, and cerebrovascular accidents. These are the common causes.
The next question, if there are changes in the eyes but no frequent attacks of migraine, does he need treatments of glaucoma?
If there are
changes in the eyes, I think he means glaucoma changes, but no frequent attacks of migraine.
Yes.
Does he need treatment for glaucoma?
Of course, if there is glaucomatous changes, whether they have migraine or not, it doesn't matter, but we have to treat the glaucoma. Migraine is maybe just an association of normal tension glaucoma. Patient doesn't need to have migraine to treat. If they have glaucomatous changes, glaucomatous disc damage, glaucomatous visual field defects, and if it is progressing, then of course patient needs treatment.
The last question, sir. Diabetic retinopathy, any guideline to refer for general practice?
Yeah, this is really important. I'm glad that somebody asked that question. Yeah, this is what they should be familiar with. Everybody must be familiar with International Diabetic Retinopathy Disease Severity Scale. That's why I explained this taking quite a time. To simplify this, basically diabetic retinopathy is divided into three categories, either no diabetic retinopathy, and then non-proliferative diabetic retinopathy, which again divide into mild, moderate, and severe, and then proliferative diabetic retinopathy, early, high risk, and advanced. And this is how we classify it. So everybody need to be familiar with this International Diabetic Retinopathy Disease Severity Scale, not only eye doctors, but everybody, because in your practice, in your GP practice, and they are managing diabetic patients, and they need to be familiar with these changes. As I showed in these images here, I showed the changes that they see, and then I showed how they should be screened. This is the WHO guidelines for screening for type 2 diabetes, because more than 20% of the patients with type 2 will have diabetic retinopathy on diagnosis. Therefore, type 2 diabetes should be screened on diagnosis. They can be done by a normal doctor, it may not be an eye doctor. Dilated fundal examination with direct ophthalmoscope. If you see any signs, then you can refer. But if you don't see anything, if you are quite sure about the fundus examination, and if you see a normal fundus, you can follow them up annually. But if you see any changes, you can refer them to the nearest eye unit for further evaluation. And the type 1 diabetics, there's hardly a very small number will have diabetic retinopathy on diagnosis. So ideally, we have to screen them within 5 years of diagnosis and then annually thereafter. So this is the take-home message for type 1 and type 2 diabetes, how to do the screening. And once we have done a study in National Eye Hospital sometime back, the first diabetic retinopathy screening, the average is after 7 years of diagnosis, which is not acceptable. Like patients have been diagnosed to have diabetes for 7 years on average before they have their first diabetic retinopathy screening, and which is not the accepted method. So on diagnosis, because I know these all the primary care physicians, they manage diabetics. So on diagnosis, do a dilated fundal examination. And if you see any signs, you can refer, or otherwise you can screen them every year. And be familiar with these signs and be familiar with the classification. So no diabetic retinopathy, you can follow up in your clinic. Mild diabetic retinopathy, if you are sure that is mild diabetic retinopathy, then again management is just follow up every annually. Like moderate NPDR every 6 months. Like severe NPDR, of course, moderate to severe NPDR, of course, refer to the eye units. And the other thing is, so part of the management lies on primary care physicians, as I said earlier, the systemic management, optimum control of systemic risk factors, lifestyle modifications. So that is again part to be done by the primary care physicians. So I hope that answers that question.
Yes, sir. And there are two more questions. Is there any treatment for JFT?
JFT.
Yes, sir.
What do you mean by JFT? Is it just a foveal telangiectasia?
I think so, sir. They have only put the abbreviation.
Okay, I suppose ophthalmologically we abbreviate JFT as juxtafoveal telangiectasia. And there are two kinds of juxtafoveal telangiectasia, which is dry type and the wet type. The dry type is the most common, which includes macular atrophy. Of course, if there is macular atrophy, there's no specific treatment as such other than this low, depending on the visual acuity, low visual aids. But if it is a wet type, which involves the cystoid macular edema, of course, then we can go ahead with the intraocular anti-VEGF treatment, depending, or the laser treatment, depending where the JFT is. So that is basically a specific ocular management. I hope that JFT, the person is referring to juxtafoveal telangiectasia.
So last question. Is there, what is the treatment for blind spot?
Treatment for?
Blind spot.
Blind spot, I mean, that is a physiological condition. You don't need any treatment. That is physiology. You know, the optic nerve head where it lies. So in the visual field, that is projected onto the temporal side of the visual field. And the blind spot of one eye is compensated by the normal visual field of the other eye. So practically speaking, there is no treatment and you don't need anything to be done. And that is a normal thing. It's a physiological thing.
Yes, thank you, sir. I think we have no more queries. So I would like to thank Dr. Mahesh Gamage for his excellent and very informative presentation on behalf of GMOS Knowledge Academy. And I would like to present a token of appreciation to Dr. Mahesh Gamage. And thank you very much, sir, for this informative presentation.
Thank you very much for the nice listening and those questions that you were quite very enthusiastic. Thank you very much.
Yes, sir. Thank you, sir. So here we are signing off today. Thank you all for your participation. Have a good day and stay safe. Thank you.